this week on the BackTable podcast.
One thing you can try, I don't know if you've ever tried this, Ashley or Gopi, but you can offer somebody just do a myringotomy. You can just say, hey, let's just make a small incision in the eardrum. Why don't you kind of test drive that for a week or so by the time it heals? And, if their symptoms are better with that, then you can place a tympanostomy tube and you really haven't, placed a tube with really not needing one. So I think that's a good technique to try on some of these patients.
Welcome back to the BackTable ENT podcast. We are your hosts. I'm Ashley Agan.
And I'm Gopi Shah.
And we have a very special guest with us today. We have Dr. Walter Kutz joining us. We've both known Dr. Kutz for a long time. He's the Associate Program Director for our residency program here at UT Southwestern.
And the Fellowship Director for Neurotology. Ashley was a resident under him. I was a pediatric ENT fellow and got to work with Dr. Kutz as an attending doing pediatric ears.
So he taught us a lot about ear surgery and otology. And, he did his training he did his residency down in Baylor and Houston, and then did his fellowship at the House Clinic.
He's super accomplished clinically as well as academically. He's part of the Triological Society, the American Neurotology Society, teaches multiple courses annually at the AAO on CSF fistulas. He's a reviewer of multiple journals, including the Laryngoscope, as well as Otology, Neurotology. And he's a dad, a softball coach, as well as a tuba player. He's a musician.
Does it all. Wears all the hats.
Yeah. So welcome to the show, Walt.
Hey, that was an awesome introduction, more than I deserve for sure, but I appreciate it. And it's great to be part of the podcast. I've enjoyed listening to the BackTable podcast, so it's great to be part of it.
Well, thank you for being here. Today, we're going to talk about chronic eustachian tube dysfunction and how to diagnose, manage, treat these patients. They are difficult.
Yeah, I agree with that. They can be challenging.
So just to kind of take it to basics, I find that sometimes it's hard to diagnose chronic eustachian tube dysfunction. You have the patient, kids that need ear tubes. You have maybe an adult that comes into your clinic and has, some ear fluid, but never had problems before. At what point do they become a chronic eustachian tube player?
Yeah, I mean, you sort of get the sense of it, right? You get the history if they've seen their pediatricians over and over, and they've had ear infections, and you see them and they have a serous effusion. But I guess technically they need to have the eustachian tube dysfunction greater than 3 months. So, I mean, if you want to look at the strict definition, but you kind of get an idea of the patients that are going to have the chronic eustachian tube dysfunction.
Yeah. And I think the easy ones are the patients who come in and have like a type C tympanogram. And you say, okay, like you have ear pain because you have eustachian tube dysfunction and we have an objective measure of it. But I think it can be kind of tricky patients who maybe have some intermittent eustachian tube dysfunction, but you see them and they have type A tympanograms. And then you kind of are wondering whether they could be a candidate for tubes or not. And maybe they have a history of saying they have ear infections, but you've never actually seen fluid and it looks normal when you see it. I think those can be kind of tricky too.
I think there's that patient, and then there's, patients that come in where, everything is sucked down. Their eardrum is on the promontory. The audio looks normal and they don't have symptoms. And those to me are also difficult, and how to manage those. Are those some of the types of patients that you see, or, what other type of phenotypes do you see, Walt?
Yeah, I mean, I think the first patient describing the ones that they have, ear fullness, they have, some intermittent pain, they're suggestive of eustachian dysfunction. They come in, but every time they come in, their tympanograms are normal. You don't see fluid, you don't see retraction. At that point, I'm probably thinking about other problems. Do they have most commonly temporomandibular joint dysfunction or TMJ dysfunctions? What I'm really thinking about if they have a normal exam. Actually, if a patient has cervical spine issues, sometimes that can radiate to the ear, and they may have ear fullness and ear pain from that. Of course, you always want to make sure they don't have any sort of neoplasm. So, a good head and neck exam is always important, especially if they have persistent otalgia. But in the patients that say, well, my ear's full all the time, or my ears are full all the time, but their tympanograms are normal, their exams are normal, I'd be very hesitant to do any more than, talk to them about allergies and allergy treatments. You may think about, well, should I place a tympanostomy tube or not? In my experience, seeing patients that have had that done on the outside coming in, a lot of times they're not very happy with the tube. They sort of feel there's a tube there and their symptoms actually worsen.
Yeah, I
One
agree.
thing you
I've
can
seen
try, I don't know
that
if
too.
you've ever tried this, Ashley or Gopi, but you can offer somebody just do a myringotomy. You can just say, hey, let's just
Mhm.
make a small incision in the eardrum. Why don't you kind of test drive that for a week or so by the time it heals? And, if their symptoms are better with that, then you can place a tympanostomy tube and you really haven't, placed a tube with really not needing one. So I think that's a good technique to try on some of these patients.
Yeah, I agree. I think I would favor that route as well as opposed to putting in a tube just to kind of see how things go. Because if the discomfort or the fullness truly is due to eustachian tube dysfunction, they should feel relief with a myringotomy, right?
Yeah, you would think so. Exactly. And then you can, just let them try the myringotomy and that's going to heal just about every time. And,
And then do y'all just see them back at like 3-4 weeks? And then if the symptoms return, offer a tube in clinic, or how do you, gauge the response and then what the next steps are in a patient like that?
I usually will tell them to call me in a week or two. They'll know probably within a few days even. Sometimes, I use a little phenol on the tympanic membrane and going through all that can give a sensation of fullness for a day or two. But after that, I think they'll kind of know is it helpful or not. And I just tell them, hey, give me a call in a week or two. And if that improved your symptoms, you can come back in and we can place a tube. If it didn't really help their symptoms, then we sort of have to start over, what is causing their fullness.
Yeah. Yeah, but it certainly rules out eustachian tube dysfunction, I would think, and you can that way you can kind of assure them that you're moving towards figuring out what's going on.
And I think one thing that you have to think about that's easily missed is, do they have patulous eustachian tube? Where they're going to get fullness, but you look in their ear, it's normal, their tympanogram's normal, but they sure have a history pretty consistent with that. And then you dig a little further and you ask about things like hearing their own voice or having autophony. Sometimes if they're exercising, they'll hear the wind in their ear. And then on exam, if you look under microscopy, oftentimes if you have them occlude their nostril and breathe, you'll see the tympanic membrane moving back and forth with their respiration. And I know, Ashley, you certainly have carved out a niche with eustachian patulous eustachian tube, and I'd be interested to see if you have more comments about that.
Yeah, I mean, now that I'm looking for it, it's everywhere. Like,
That's right.
I don't think I ever
That's how that works.
diagnosed it. I don't think I ever diagnosed it in residency. And then now I've seen so many patients with it. And sometimes, speaking of patients who get a tube and then still have symptoms, I've had some patients who come in and that's their presentation is that, I had stuffy ear and then I got a tube and now I just feel like I'm still stuffy and I feel like I'm talking in a barrel and it's terrible. And it's because they have patulous eustachian tube. And then the other thing about being able to see the eardrum move when they're breathing, they need to be sitting up. So if you lay them down to look with a microscope like you normally would when you're doing otoscopy in the clinic, you probably won't see it because usually their symptoms are better when they're laying down because you get that kind of edema of the eustachian tube when they're supine. But as far as taking care of those patients, I've been doing just transnasal endoscopic eustachian tube plugging with a shim, which is just a angiocatheter filled with bone wax, and those are probably my happiest patients. I've had really good results so far, so it's pretty incredible.
Those patients with patulous eustachian tubes, they're oftentimes, it takes a long time or see multiple doctors to be diagnosed and they're very frustrated. And, I could see, if you're able to improve that, they could be very appreciative, very annoying symptoms.
Mm-hmm. Yeah, absolutely.
In terms of patulous, in terms of diagnosis, for the difference between, eustachian tube dysfunction and patulous, what are the 2 or 3 things in the history that you find that are different? And then do you end up scoping them, and what do you find on your scope findings?
Yeah, I'm gonna let Ashley. I think Ashley's really has expertise in this. So I'm gonna say I'm curious to learn a little bit. So what do you do, Ashley?
They definitely can come in and look the same at the beginning with that clogged, stuffy ear feeling. So they both can have that. For patulous patients, the autophony to either their breath or to their voice and having symptoms better when they're laying down is pretty unique to patulous. The eustachian tube dysfunction patients, in my experience, aren't going to have those. So if you can ask the right questions and kind of pull that out, it's helpful. But, similar to our dizzy patients, I think sometimes our patulous patients don't always know how to describe what they're feeling or experiencing. Sometimes I've had patients lately, I've had a couple that say their ear feels heavy. So they may not even, if you say, is your ear clogged or stuffy? They're like, no, it feels heavy. So sometimes they don't know how to describe what they're feeling. On exam, if I can see the eardrum moving when they sniff, that's awesome. Like, I'm like, oh, yep, there it is. This is what you have. But I don't always see that. And then our audiologists have actually started doing some testing when they're doing tympanometry, where they can measure whether the eardrum is patulous. And then they also have a test that they do that measures eustachian tube dysfunction, where they're having the patient basically try to Valsalva and clear their ears while they're doing the tympanometry. And so that's been helpful to try to get some sort of objective information. It doesn't always show up on that either. But if we're going to the operating room, I would really like to be able to see the eardrum move. But if I can't, if we've ruled out everything else and their history is consistent with patulous, then I've had good success with that.
And then on your nasal endoscopies, do you do that pretty much for all these patients?
I think I usually scope all patulous and eustachian tube dysfunction just to kind of see what's going on back there. And the more I look for patulous patients, the more I can start to see it. You really need to be looking up into the eustachian tube. So you either need to use a flexible scope and look around the back of the septum so you have the right angle. So if I'm looking at the right eustachian tube, I'll go in through the left side and turn and look around. So I'm kind of got the angle, or use a 30-degree scope to be able to look up. So
you'll do opposite side with your flex and snake it up. And then with the other one, or with the rigid, you're doing like a 30-degree.
Yeah.
Okay.
Yeah.
And when you're looking up into the orifice, is it a couple millimeters in? And are you seeing that there's space? And so you're like, oh, that's patulous? Or is it?
Yeah, it's not, I don't know if I have a perfect way. Like it's very much like a feeling. Like you kind of look at it and you're like, that looks kind of patulous. You will see, for some patients, you will see a gap.
Okay.
And when they sniff, you might see it kind of come together. Sniffers, that's a common patulous symptom too, patients who are sniffing a lot, because when they sniff, it kind of pulls the eustachian tube closed and they'll get relief of symptoms. But Dr. Kutz, an interesting patulous patient would be the patulous patient that also has like retraction or cholesteatoma. That can happen too, right?
Yeah, you were mentioning, these chronic sniffers, I think they like having the kind of negative pressure, kind of relieve some of that autophony. And so, yeah, if someone is constantly sniffing and that tympanic membrane get pulled in enough to create a cholesteatoma, and, we oftentimes think cholesteatoma occurs only from eustachian tube dysfunction, where you have this chronic negative pressure.
Right.
But I've seen it in patients that are chronic sniffers as well. And the challenging thing about that is going to stop that habit. It is a very hard habit to break.
Wow.
It's almost like your throat clearing patients or your chronic cough patients. It just becomes something that they're just kind of doing without.
So if you have a cholesteatoma in a patulous patient who's a chronic sniffer, in terms of let's say, you have to, do a tympanoplasty, pacilmastoid, you have to repair the drum. Are you always, pretty much using cartilage at that time? I guess my question is, what's the success rate for repairing the drum with a chronic sniffer?
I think it's probably similar. I think I worry more about if they don't break that habit, that they may create another cholesteatoma. So I would certainly use cartilage in those patients. Okay. I've never thought about, if they're still sniffing, trying to shim or something like that. That's just something you could try. You could, if they're starting to retract, you could put a tympanostomy tube in. Hopefully they'll tolerate that being with the patch eustachian tube. And some patients actually that helps them somewhat. But yeah, I think you just have to use a lot of cartilage and then try to convince them to stop that habit. I've had a few patients that have actually stopped the habit or made it pretty seldom where it's not causing problems.
And you would think that if you're using cartilage for your tympanoplasty, that would help with the patulous symptoms too, right? Because the eardrum is kind of heavier and less likely to move when they're sniffing, maybe.
Yeah, that's a great point. That's actually one of the treatments for patch eustachian tube. If they have you can actually do a cartilage tympanoplasty. Sometimes you can place like a paper patch with some bacitracin ointment, make the tympanic membrane heavy, and sometimes that'll improve the symptoms. Then you can consider doing a cartilage graft tympanoplasty. That's as part of the treatment for patch eustachian tube, even without a cholesteatoma. I've really not done that often. But.
Yeah, I've done that in clinic to kind of try to just figure out if it is patulous before, like if it kind of sounds like patulous, but everything I can check is negative. I've tried the whole, to just weight the eardrum to see if that helps with their symptoms. And I think that's can be helpful for sure.
Mm-hmm. Hey, Ashley, do you have good success using topicals? People will use topical estrogen nasal drops, or there's this patulin. Do you try those with the patients that have patch eustachian tube? And what is your success?
I do usually have them try patulend. I have not had a lot of success personally, but there are some patients who I haven't seen back. So it may be that there are some that use it and then don't come back to see me because maybe they're doing better. Or I'll have some patients who say they use it and maybe it helps a little bit, but usually the ones that I'm seeing again it's because it's not working, and it does burn, so it's uncomfortable to use because the whole point is that it's trying to create some inflammation and puff up those tissues, the eustachian tube.
So actually, going back because I do peds, I don't really see much patulous eustachian tube. Can you explain the drops, like the pathophys, like why what it's supposed to do?
Yeah.
And what patulend is.
Yeah. Patulend is a drop that was developed by a physician in Santa Barbara, California. And you put it in your nose and you kind of hold your head such that your eustachian tube is kind of the most dependent part of your head, and put the drops in your nose so that their drops are kind of going down and sitting right at the orifice of the eustachian tube. And it's just it's a compounded medication, like a supplement. So it's not a prescription. It's just a proprietary formula that is meant to create some inflammation in the mucosa and make it kind of
bulk up
puffy so that it'll close. Yeah.
Got it.
And then I'm not actually sure about how the physiology would work for the estrogen drops. I've heard of people using estrogen drops. I haven't prescribed them before myself. Do you know, Dr. Kutz?
I mean, I've tried them. I think it's the same sort of thing. It just irritates the eustachian tube and causes some swelling. I've had poor success. I think part of it is that you have to place the drops the correct way. You have to have your head sort of turned to the side so that the drops actually stay on the eustachian tube orifice. If not, they'll just go right down the nasopharynx. So I think it's important that if you're going to try those drops, which I haven't had a lot of success with, I think it's important that the patient, administer them the correct way, or it's definitely not going to work.
Right. And I've heard and read that a tube can be helpful for like the clogged and stuffy feeling, but not so much the autophony. But I personally haven't had a lot of success with it. What about you?
I'm the same way. I mean, I haven't a lot of success with a tube. You could always, you could try myringotomy, see if they like that. Just, you don't really have to commit to the tube, but I haven't had that much success with placing tubes for patulous eustachian tube dysfunction.
Yeah. But placing a shim, I would say, works great.
That's awesome.
It's the patients are super happy. And
what does the bone wax stay there for? Like when you're counseling the patient and you're discussing the shim surgery, what do you tell them? Like, hey, this is good for a year, 6 months, 5 years, or do we know yet?
The longest study that looked at patient outcomes at 12 months, and about half of patients had recurrence of symptoms. Okay. So, and that's with the shim, which is kind of the best one. So with the other techniques, there was recurrence of symptoms earlier.
Wow. Okay.
So it's meant to be there for a long time. It can fall out. One complication that's really common is that you kind of overplug it and then they get fluid and you end up putting in a tube.
Oh, gosh.
Of course,
that's going to happen.
Yeah. It's a very fine line because you're trying to, plug it just enough so that they don't have symptoms, but that they still have some way to kind of move air around it. So, but most of them are willing to try anything because they're just so frustrated and annoyed by hearing their voice echo with all the time, voice and breath.
And so when you place the shim, you're using a rigid scope, a 30 degree or a 0, but
30. Yeah, so you can see.
And then what kind of, are you using just a cold knife to make an incision?
Oh, no, there's no incision.
Oh, you just inject it.
You just kind of insert it up into the lumen of the eustachian tube, and then it wedges at the bony eustachian tube.
It's a special catheter.
It's an angiocatheter.
That's it. Okay.
Yeah.
Is there certain length to it?
I do 40 millimeters.
That's cool. Okay.
Yeah. Yeah, I'll show you. I'll make
I'm
a video.
like,
I'll
I need
show
to
you.
like get out of children's one day and come see what people like the real stuff. Man.
Yeah, but yeah, I mean, I think patulous isn't super common, but for the patients who are experiencing it, it's a big quality of life issue. So
Yep.
it's nice to be able to have some tools to help them. Flipping it back towards, the opposite problem when patients have eustachian tube dysfunction and their eustachian tubes just don't work. These can be really tricky patients too.
Yeah.
And particularly, I think about the ones who keep extruding their tubes or who have had two T tubes and then, they get a perf or they just have chronic drainage. Dr. Kutz, talk to us about those patients because those can be
Those are hard.
really
We
tough.
see them in adults, adolescents, craniofacial kids, which is a different, but I'm just talking about, I agree, that otherwise healthy adolescent adult patient. Those are tough. What are some pearls? How do you manage it?
Yeah, I don't know if I have any perfect pearls for that. I agree. They're very challenging for sure. I don't like going to T tubes, too soon, I guess. I'll try grommet tubes for at least a few tries. And then, if they're going to definitely need tubes, we'll put in a T tube. I just think there's a high risk of a perforation. And honestly, if these patients have a perforation, it may be the best for them, right? It's kind of a chronic or a permanent tube, I guess, if there's really no
Mhm.
such thing, but a perforation can kind of act like that. But the problem with the T tube, you get a pretty big perforation with
I was
those
gonna
that can
say,
cause
yeah, they
hearing
tend
loss.
to be big. Yeah.
Yeah, they really do. And so, I think you're just doing the best you can to manage the patients. You bring them in, keep putting tubes. And then I've had some patients that place so many tubes, their tympanic membrane gets very atrophic. And,
Yeah.
you're worried, are they going to even be able to have a tube, retained because of the thinness of the tympanic membrane? And on a few occasions, I've actually done a cartilage graft tympanoplasty where I've just placed a T tube through cartilage, just lifted the drum, cut out a little bit of drum and do that. And I've had good success with that. Again, that's somebody that's had, multiple sets of tubes where there's really not much of a tympanic membrane to even retain a tube anymore. And, you know, that's kind of my approach to tubes. I've really not done subannular tubes. People describe you can make a small
Right.
little passage in the ear canal, then under the annulus of the tympanic membrane, and you place a T tube through there, and that would probably last longer. But you still have the risk of the lumen of the tube becoming blocked. Right, the T tube's kind of
Mhm.
long, kind of a small diameter, so they can get blocked. So those aren't perfect either. So I just manage them the best you can.
For the cartilage with the T tubes through them, how long do those tubes stay in for usually?
Well, the ones I put in, I've been in practice 13 years. I think they've all that I can recall have stayed in. Again,
Okay.
I think the biggest risk of the tube's going to, become blocked, and then you can just take the tube out and replace it because now at least you're not going to get a large perforation, right? Because you made a
Mhm.
small controlled hole in the
Right.
cartilage. So,
Mhm.
if you have to take the tube out and place another tube, I don't think it'd be a very big deal. But so far, I haven't had a problem with that. They've seemed to, as far as I could tell, as long as the patient came back, I've had good success of those staying patent and in place.
Yeah.
And
Speaking of the atrophic drum, I've had kids that I've taken to the OR planning for regular tube or a T tube, whatnot. And it just with the nitrous and just, mass ventilation, that eardrum just turns into a balloon that's lost all elasticity. And to the point where it's hard to make an incision or figure out where your incision was and things, that eardrum's kind of flopping in the breeze. Have you found yourself ever in situations like that? And do you decide to still try to get a tube in or just call it? Or I find that happens every once in a while, and I just feel like I'm not sure what the best thing to do is next.
Yeah, I've had that happen a few times. I seem like I go and place a tube. I sort of look at it. Let's try the tube, and I don't recall the success of that. But if the tube takes and their drum becomes more normal with the tube, that's great. If they end up developing a small perforation, then you could probably do a cartilage graft and panoplasty, which it sounds like they may need anyway
Right.
if the drum's that floppy. So I'd probably go and place a tube if I thought I could do it safely. I could see landmarks and those sort of things. I don't know, Ashley, have you had that situation?
yeah, yeah, I've seen that. It's
Mhm.
frustrating.
Yeah.
You're
It
like, it's just a
almost
tube, man. It's
Right.
straightforward.
I'm like, the anesthesiologist is looking at me like, "We're still masking. I'm still masking, right?" I'm like, "I know, but here we are. Here we are 20 minutes later sometimes."
Yep.
sometimes tubes can be very humbling, but I've heard of people using a laser to try to tighten the drum for things like this. Have you ever done that, Dr. Kutz?
I don't. Some people have done that. I believe a CO2 or carbon dioxide laser is a little bit better for that. I don't use carbon dioxide laser. I use a 532 nanometer diode laser. I haven't done that. I know Brandon Isaacson has tried that on a couple patients, and I don't think he had all that great of success, but it's been described in the literature, but I haven't had much success with that. I think it just, if it's that atrophic, you're probably going to create a hole in the drum anyway.
Yeah.
And
Sometimes it's really
yeah.
flimsy.
Mm-hmm.
And then do y'all see how some of these patients, I've had a handful where the tube medializes. And I feel like it's in some of these chronic ear eustachian tube patients
Mm-hmm.
where literally they've had a tube where, and it's, medialized into the middle ear. Do you feel like eustachian tube dysfunction or the severity of it is related to tubes occasionally getting medialized into the middle ear? Or is that just a bad outcome, just, bad luck, it just happened?
I think it just happens. I've only seen that a handful of times, so I'm not really sure if it's a higher incidence in somebody with eustachian dysfunction that's more severe than others. I typically will just leave the tube. If it's not causing problems, I'll leave the tube in place. We leave titanium, silastic, all kinds of materials in the middle ear space and for, lifetime. And, tubes are pretty inert. And so if they're not causing problems, I would just leave the tube in. Sometimes I have had with it, if they need another tube, you can make a small incision, retrieve the tube and place a new tube. I did have one patient that had some kind of vague otalgia, some irritation, and she was really convinced it's from the tube. I just did a tympanotomy and just lifted the tympanic membrane and removed the tube, and she was better. I don't know if
Hmm.
for whatever reason, but generally speaking, I'll just leave the tube in place unless it's causing some problems.
Yeah, I agree. Because sometimes you could go in trying to get it out, and you've had a perf or if it's not broke or causing. Yeah, I totally agree.
So putting in tubes should theoretically relieve the eustachian tube dysfunction, right? Because you've kind of bypassed the need to have a eustachian tube. But if you have these patients who are still having issues where they're either their tubes are falling out or they're always clogged or they're having a lot of drainage, at what point do you start to consider actually doing procedures directed at the eustachian tube or nasopharynx, things like that?
You mean like the balloon eustachian dilation procedure?
Yeah, like just either adenoidectomy or balloon, or
Okay.
some people will do like eustachian tuboplasty and like get the microdebrider and take down, if the eustachian tube has become, sometimes you'll get some like a lymphoid hypertrophy of the torus. Yeah. I mean, how does that come into play in your practice? Or does it?
For me, I think for adenoidectomy, I think if it's their second set of tubes, I would do an adenoidectomy. I think I should think about an adenoidectomy more frequently for these patients with chronic eustachian dysfunction that are older than your 3, 4, 5, 6-year-old. I don't always think about that, but it's not a bad idea if they have adenoid hypertrophy and they're getting recurrent retraction. It's probably, it's pretty low risk to remove adenoids, and that could potentially help. Like if you're talking about like lymphoid hyperplasia around the orifice of the eustachian, I've never removed that before. I have no experience doing that. I'd probably try to treat them medically with nasal steroid sprays. Ash, have you ever done that or had success with that?
I think that the balloon is probably the most helpful, but I've had patients where they have big adenoids and they also have, it looks like their adenoids are just kind of continuing like onto the mucosa of the eustachian tube, and I'll use the microdebrider to kind of trim that. It doesn't come up that often, but I have done that before.
I wonder if that helps it scar laterally, or I guess medially. Like, do you think it helps the torus kind of scar medially to help open it up? Or
I don't know. The more I look at eustachian tubes, the more I feel like most of the problem is intraluminal. And so I think that's why the balloon works so well, is because, when they did studies looking at the mucosa after balloon, there was actually
shearing of the cartilage.
Yeah, there was change in the inflammation within the mucosa. And so it's something about that squishing and crushing is actually changing how that tissue is acting. And so sometimes patients will have terrible eustachian tube dysfunction, and I look back in their nose and there's not a ton of adenoid tissue. There's not like an actual physical obstruction blocking the tube. It's just within the lumen of the tube, it's just swollen and not working. I don't know.
Yeah, I think the balloon's intriguing, and the struggle now is getting insurance to approve it. And I've had, I can recall one patient that had an acoustic neuroma and removed the acoustic neuroma and it was a large tumor. They didn't have hearing. They lost the rest of the hearing with the surgery. And then on the other ear, they were getting recurrent serous otitis media. And of course, when they have that, their hearing would drop terribly and they couldn't communicate. And I
Yeah.
placed 3 tympanostomy tubes. And at some point, you're like, do I want to keep placing a tube in an only hearing ear with the risk of perforation and that very small risk of a secondary acquired cholesteatoma or some other issue? So they actually pay cash for the balloon
Mm.
procedure, which, if you look at literature, all comers is maybe 60% successful, somewhere around there is what I usually tell patients. But we did the balloon, and 2 years later, the patients had no further problems with serous otitis media. And, I think, in my opinion, the balloon's most effective for patients with kind of mild to moderate eustachian dysfunction, like your flight attendant or your diver or somebody like this patient that is having recurrent serous otitis media and only hearing ear. It seemed like the balloon could be very useful for those patients. I think the patients that have these just terrible eustachian tubes that you get retraction pockets within 6 to 9 months after surgery for cholesteatoma. I don't know how well they'll do with the balloon. But the real frustrating thing is just it's really hard to get reimbursed for it.
Right. Yeah, I've experienced that a lot lately too, which is unfortunate because
Mhm.
it's nice to have something to offer to patients, but then when they turn around and it's not covered, then it's frustrating for everyone because
Right.
I feel like they're looking at you like,
Why are you trying to sell me something?
Yeah,
Yeah. Why are
why'd you
trying to sell me
recommend this
something?
if I it's
Yeah,
thousands of
it's
dollars.
challenging
So
for sure.
Yeah.
yeah. So yeah, it sounds like in your experience, patients who just have, these chronic ears where they have chronic retraction or cholesteatoma, that you just kind of have to address the eardrum, and the eustachian tube itself may not have a good solution yet to fix that, but you kind of have, work around it by addressing the eardrum.
Yeah, I think I still think, unfortunately, we just have to address the problems that the chronic eustachian dysfunction causes. Maybe if we get more literature on the balloon, we can, figure out which patients would benefit or not from that. And and I not infrequently, if somebody has recurrent retraction, I've done 2 or 3 surgeries, but they've retracted. I'll place a tympanostomy, like a T tube through cartilage, just during the tympanoplasty. And again, I've had very good success with that. It's always that I can't tell you it perfectly when I do that and when I don't do that. It's sort of a gestalt and knowing the patient, and
Yeah.
usually it's on a recurrent retraction pocket, thing like that. But that's always an option. And yeah, again, like Ashley was saying, you sort of have bypassed eustachian tube at that point.
Well, one last question for you guys. How often do y'all think about allergy or do an allergy evaluation for these patients? I feel like, in some of my, more so my adolescents, my as young as 10, once we're like on a fourth, fifth set of ear tubes, or just if their eardrum, every time I see them, it's, medialized and retracted and, maybe they may or may not have a little bit of an earbone gap. But how often do y'all maybe send them or do an allergy evaluation on these patients, or think that's, a contributory factor?
You read my mind. I was about to bring up allergies too. For me, I send people for allergy testing and consideration of allergy immunotherapy when when they're failing kind of the maximum medical therapy. So, I like nasal steroids as a starting place. So like Flonase or Nasonex or something like that. And then sometimes I'll add on like elastine nasal spray, which is a nasal antihistamine spray. May have them use decongestants occasionally, like, Sudafed behind the counter, depending on what kind of medical comorbidities they have. But once they're not getting any benefit out of those, I think it can be helpful to do allergy testing and consider allergy immunotherapy. What about you, Dr. Kutz?
Yeah, that's a similar approach I have. If they've never really tried allergy therapy, you're going to probably do that before allergy testing, right? Allergy testing is going to be if you're going to consider immunotherapy as part of their treatment. I mean, I think one of the interesting, some patients you sort of think allergy, but they don't have the nasal congestion and the itchy eyes, the sneezing and things. I don't actually. Do you still think allergy sometimes, or how do you differentiate? Do they just have eustachian tube dysfunction? Is that their only allergy symptom, or or do you more look for those other symptoms of allergies, like the nasal congestion and things?
Yeah, if patients don't have the sneezing, runny nose, itchy eyes, nasal congestion kind of symptoms, then I feel less confident that they're going to benefit from starting
Hmm.
Flonase. But I will still talk to them about giving it a try,
Hmm.
especially if we're struggling with finding, if they've had tubes and their tubes are falling out, or if they've had a tube and they're still having symptoms or stuff like that. Do you ever have patients do like the otovent or the ear popper, or have them Valsalva and clear their ears,
Chew
several times
gum,
a day?
yawn.
Yeah, that's actually a good point. Sometimes you'll see patients that have a type like a chronic type C tympanogram. They do have some fullness, or maybe they have a type A, but you're sort of convinced they have some mild eustachian dysfunction. I'll have them, auto-insufflate in the clinic, do a Valsalva. And if I can see that drum moving and they're able to clear their ears, I'll tell them, hey, do that 6, 8, 10 times a day. And then, oftentimes if they're doing that, you don't need to place a tympanostomy tube. And I have used some of the ear popper otovents for some patients. I always feel that, if they can, they're probably either going to be able to auto-insufflate on their own, or it's going to be so severe, even with the ear popper otovent, they're not going to
Mhm.
be able to insufflate their ears. So I think it's reasonable to try that. I've had a few patients have success. They like using it. It makes their ears feel better. So I think it's worth a try. And I think now you can get these things for, I think the otovents, $15-$20, and the kind of ear popper sort of devices are around $60 now. So I mean, patients could try these, and they're not $200 or $300, anything of that sort.
Have y'all ever used these in your, teenage patients or, 10-year-old patients?
I was gonna ask you, Gopi, have you had experience?
I
I haven't tried that.
I haven't I think I've recommended it before to that sort of 8-year-old and up where, again, they've had, anywhere between 2 to 5 sets of tubes and the parents are just done with it. I think I've recommended it. They, a lot of times because of cost, families may not get it. Once they, I'll show them a video, like a YouTube video, so they know what it is, and that may or may not kind of intrigue them. So I haven't had too much experience with it. So I tend to just try that. Okay, we'll try to yawn and pinch your nose and swallow and chew sugar-free gum, and that they end up coming back, most of them, and we end up having to do other things or just follow them and see how they do. A lot of those families, even if the patient doesn't have allergy symptoms, some of them will take me up on, all right, let's do an allergy eval because maybe there's something mild because it's usually spring to summer when there's an effusion and it might clear up in the fall. Or so I still feel like it's kind of nebulous, and you end up kind of just trying to work with the parents and the child, and a lot of it, is going to be other things like school and how they're doing with hearing in class and their grades and at home, and quality of life as well. So it's
Yeah.
definitely
I think the otovent's a good thing to try. We have it in our clinic, and we can just sell it to the patients kind of on the spot, and our nurse will, usually with the pediatric patients, our nurse will show them how to do it. And since it has the balloon, it's kind of
yeah.
more, they kind of make it like a game. And so I definitely think it's worth a try, and you're not losing much. So, but what do you say to patients, Dr. Kutz, who I've had patients ask me how how hard they can try to clear their ears safely. Does that make sense?
No, it does make sense. I mean, I guess you worry about like creating barotrauma or a perilymphatic fistula. It'd be pretty difficult, I think. Trying to clear their ears. If they're able to clear their ears, they're probably, if it's difficult to clear their ears, they're probably gonna have a hard time causing harm by trying too hard. I can't recall a patient coming in that's harmed themselves trying to clear their ears, but I would probably tell them this. I mean, just because there are some personalities out there, I'm gonna win no matter what, right? And so I'm
Right.
gonna pop this ear, and then I think they could technically cause problems doing that. So,
Yeah.
but the really competitive patients, right?
Right.
But yeah, I mean, I agree. When I watch them, a lot of times I watch them in a clinic, and so I can say, hey, okay, that's good. And
Yeah.
that's, if you can't pop it trying that hard, you're not gonna be able to clear your ears. So,
Yeah.
but
That's good
every
advice.
now and then you'll have a patient that you get diving injuries. That's usually where they aren't clearing their ears, but they just have so much negative pressure. And I recall a patient that was doing really vigorous setups one time, and they caused a perilymph fistula. Again,
Oh,
not
wow.
clearing their ears, a little different mechanism, but Yeah, I haven't. I've never. I cannot recall seeing a patient that's caused damage doing a ball saw or insufflating their ears, but I guess it's possible. I don't know if Ash, have you ever seen that, or do you recall
I
that?
haven't seen it. No, I'm kind of like you. If they're doing it in clinic and it looks like they're trying really hard and nothing's happening, then I'll just say,
Yeah,
okay, it looks like you're
yeah.
not going to be able
You
to.
win. You win. It's good. You.
Yeah, that's enough. What, some people talk about the middle ear as it's like another sinus, right? And can talk to us about topical steroid therapy for the middle ear in the same way that we use Flonase, as a topical treatment for the nose and sinuses. There are some patients that I think benefit from having topical steroid therapy to the middle ear on a regular basis. Usually patients who have a tube but just are kind of always having drainage or kind of always have that middle ear inflammation. Do you see that?
I do see that. Oftentimes I'll treat them with a combination fluoroquinolone steroid like Ciprodex, and I don't know if it's the Cipro or the dexamethasone that's helping. I have patients like that have eosinophilic otitis media. It's a very difficult condition to treat, and I'll place those patients on chronic steroid drops. I mentioned off-label use here. Sometimes because of cost, you can use ophthalmic dexamethasone. It's pretty inexpensive
Mm.
because these patients are going to need these drops for maybe ever.
Yeah.
So yeah, that's kind of when I think of, or these patients get a lot of polyp changes in granulation tissue. If there are these chronic tubotorrhea patients are very challenging. Gopi, you may have more experience than I do with these patients. It seems like we see that more in the pediatric
Yeah.
population. I'm curious, how do you treat
I
those
you know,
patients?
it's oral as much as I can oral toilet. So I have 2 groups. I think of it as 2 groups. One is the otherwise healthy kid that has some tudotorrhea that you can do the oral toilet, suction in clinic, try some mastery powder, try a little Ciprodex, have them come back, maybe suction them out again, make sure it's not a fungal otitis externa. And depending on how they're doing, you might have tricks such as, well, peroxide diluted with distilled water to kind of just, you know what I mean, thin out the junk and then, Ciprodex if you need it, or versus, hey, this is not bacterial, Volsol or like white vinegar, distilled water type stuff, dry ear, hair dryer kind of thing. And then I think of my other patients that are like my primary ciliary dyskinesia patients that just have that chronic thick mucoid tubotory. And that's a little bit different, right? There's a different reason for it. For those patients, and it's hard because I'm actually one of my younger patients comes to mind. She's 4, and she's chronic tubotorrhea. Obviously, she doesn't want to be papoosed every time she comes to clinic to get her ears sectioned out, and I don't want to do it either. So just because otherwise she's not going to let me look in her ears in the future. So what I have the family doing is, those blue bulb syringes, the baby ones for the noses, because it funnels out, they can't really put it in too deep. And I always tell them don't put it in more than 5 millimeters or so. But they, and she basically sucks out the child's ear before bed. And she'll also do couple times a week, a little diluted peroxide with distilled water. It doesn't burn. I always ask, does it burn? Sometimes she'll use Ciprodex, just something to thin out the mucus. And it seems to help. When I see her in clinic, there's always a little drainage around the tube, but you can actually see the tube. Her audios are normal and her speech is good. So that's what I do for her. Every once in a while, will I just bite it, just be like, God, this has been going on for a long time. We just need to take the tube out. And obviously we want to make sure we're not missing anything like a cholesteatoma or, something underlying that, God forbid, like an acquired or something. And every once in a while that can happen too. I'm not quick to scan unless I'm really concerned for a cholesteatoma or something. Sometimes I'll have patients come to me for tubotorrhea after they've had like a CT scan, so I'm definitely not quick to scan. And then every once in a while, if it's a younger kid, again, 4 or under, and, they have other, recurrent history of pneumonias or other bacterial infections, so I think of, maybe we need to consider something like cystic fibrosis or an immune workup. So that's kind of how I think of tubotorrhea in those little buckets, I guess.
Yeah, that's helpful. It's very challenging and frustrating. I think everybody, get some tricks to try, and certain things may work for different patients that may not work for another patient. But those are good. I've learned something there for sure.
and
I'll
and
steal those ideas from you.
Right, right.
Dr. Kutz, you mentioned eosinophilic otitis media. How do you diagnose that?
Well, a lot of times they'll have asthma as well, as part of their systemic illness, but it's, they just get this really tenacious granulation tissue. A lot of times you place tympanostomy tubes, you have granulation tissue growing out of the tubes, and it can be somewhat resistant to even steroid drops. It's very challenging to treat. There's some systemic therapies that work for the asthma aspect of it that you can try. That really haven't been many studies for the otitis media aspect, but it's a challenging condition to treat. And you sort of, oftentimes I'll send them to an allergist to kind of work all that up. But you kind of see these patients. I mean, they have really thick drainage and granulation tissue, and just very unusual. So when you see a couple of these patients, you go, okay, that's what that is.
Yeah, just a very classic.
Yeah, it's bilateral, right? Because it's a systemic problem.
Yeah. Wow. Well, we've kind of been all up and down around the eustachian tube today.
It's been great.
Eustachian tube dysfunction, patulous eustachian tube, tubes.
It truly is a eustachian tube disorder. Top.
Yeah,
for sure.
Yeah,
exactly.
Have we missed anything, Dr.
Yeah,
Kutz?
any
Was there
pearls
anything
or
that you wanted to impart before we land this plane?
So I would, one of the things, these patients present with ear fullness, probably the most common is eustachian dysfunction. And then, you need to think patulous eustachian. We talked a lot about that, TMJ dysfunction, but another condition to think about, superior canal dehiscence, which we can go on for another hour about that. We won't do that.
Maybe for the next time.
Yeah, for the next time. But those patients, they can present with just fullness in their ear. And you've looked at all these other problems. And typically, just real quickly, if you do a tuning fork exam, they'll typically hear the fork in that ear. A lot of times they'll have a kind of a conductive hearing loss with intact reflexes. But think about superior canal dehiscence as a much less common cause of chronic ear fullness, but one you don't want to miss. Just, it won't harm the patient, but, you're going to do all these sort of treatments for eustachian dysfunction and patch eustachian tube, and really they just have superior canal dehiscence. So that's, I would add that in there, something to think about.
Yeah, for sure. And you get a CT temporal bone to evaluate.
Yeah, and then you're going to see missing bone over the superior semicircular canal, and there's you can verify that with VIMP testing and go from there. But I think it's one diagnosis to keep in mind, a differential diagnosis for chronic ear fullness.
Yeah. Awesome.
Sounds great. Well, thank you so much for your time, Walter. I learned a ton. I enjoyed it.
Thank you for having me, and enjoyed it. As a difficult topic for sure. And I learned a lot. I think talking to people about it, how they treat eustachian dysfunction is helpful. So,
hey, well, next time you're bringing your friend the tuba. Okay?
Oh yeah, we got to. That's right. We'll bring in the tuba next time. So you got to look for the next episode.
Right. So. And if people want to look you up and learn more about you, where can they go?
You can go. I'm on Twitter for EarDoc1 is my Twitter and Instagram handle. Awesome. Actually, Instagram is Walter Kutz MD. Twitter's EarDoc1, and then if you want to go to my website at UT Southwestern, it's drkutz.com.
Awesome.
drkutz.com.
Love it.
Awesome. Very good. Thank you so much, Dr. Kutz. It's been
I really
fun.
enjoyed it. You guys have a great day.
All right. You too all. See you later.
Alrighty.
Bye. So we just want to thank all of our listeners for tuning in today. We're excited for upcoming podcasts with you all. We are open to suggestions, topics, or if you want to come on the show and be a speaker, we'd love to have you.
Yeah, please reach out to us. Let us know what you thought about Dr. Kutz and eustachian tube dysfunction. We'll see you back here real soon. Find us on Twitter. Our handle is @_BackTable ENT. And we will see you next time. Be well.
And it's a wrap.
It's a wrap.